CMV, or cytomegalovirus, is a DNA herpes virus that, after primary infection, meaning initial infection, can become latent and then be reactivated sometime down the road. CMV is the most common congenital viral infection, meaning the most common infection in a neonate that is acquired during birth, with 90% of neonates being asymptomatic, meaning no symptoms, and 10% being symptomatic, having symptoms. If the neonate is born with symptoms, they are at a higher risk for adverse outcomes. Hearing loss is the most common adverse outcome of a CMV infection in pregnancy, with up to 50% of symptomatic neonates being hearing impaired and about 25% of asymptomatic neonates being hearing impaired. When a pregnant individual gets a CMV infection, 90% of these people have no symptoms whatsoever, and then the remaining 10% may have fever, rhinitis, pharyngitis, myalgias, arthralgias, headache, or fatigue, and she did have symptoms. And she had her infection, I think she said, about 3 weeks before she delivered. To date, no professional societies or government health organizations recommend universal CMV screening in pregnancy. And there are numerous reasons for this. Number one, there's no vaccine available if you were to screen a pregnant individual and they've never had CMV. Number two, even if you screen a patient and they've had the infection in the past, they're still at risk for reactivation of CMV when they're pregnant. Third, if we happen to diagnose a primary CMV infection or a reactivation of an old CMV infection in pregnancy, and even if we were able to test, and that would be through an amniocentesis, to see if the fetus is potentially affected, there's no way for us to be able to tell if it's really affected or if there's going to be adverse outcomes to the fetus and neonate from that infection. Now, some practices will screen the following patients: those with a known exposure to someone with CMV, number two, patients with HIV, and number three, patients who are immunocompromised for any other reason. Now, neonates are at greatest risk of having adverse outcomes from a maternal CMV infection if there is a primary infection in pregnancy, number one, and number two, the later in pregnancy the patient has that primary infection. With a primary infection in pregnancy, the risk of congenital infection is 36.8% in the first trimester, 40.3% in the second trimester, and 66.2% in the third trimester. Although the risk of fetal infection is greater as the pregnancy progresses, the risk of having adverse outcomes from that infection are less as the pregnancy progresses. The risk of the neonate having an adverse outcome from a congenital CMV infection is about 19% in the first trimester, 0.9% in the second trimester, and 0.4% in the third trimester. The final thing to know about CMV in pregnancy is that the earlier in pregnancy the patient has the infection, the more likely we are to potentially see things on the fetal ultrasound. There's a whole list of markers that we can see on a fetal ultrasound that would warrant a potential investigation into whether or not there has been a CMV infection in pregnancy. If we see these markers on ultrasound, we would first test the patient for a primary or recurrent CMV infection, and then offer the patient amniocentesis to check the amniotic fluid for the presence of the virus in the amniotic fluid. Well, everything I just said sounds terrifying, and if I were pregnant, I would be terrified too. We can't do anything even if we were to diagnose CMV infection in pregnancy. And that also doesn't mean that every time a pregnant individual has cold or flu-like symptoms, they should be tested for CMV, because again, there's nothing we can do. So that's why a universal hearing screening in the neonate is very, very important, because that's where most of these cases of congenital hearing loss are picked up.